Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for March 9th, 2023. Today's CME activity code is 487946. Before we start, I want to wish everyone a happy Holi. And yesterday was Women's Day, and today is World Kidney Day. And it's also called Sakatuam Kidney Day, so I hope you all have your kidney socks on. I have mine. I'll spare you looking at them, but it's a really fun day and a lot going on. So let's celebrate everything that's good. Today we've got a great case with Dr. Whittier, Dr. Schlattman. We have nothing to disclose, and patient confidentiality is totally preserved as always. We're going to read the protocol, and then we're going to have a couple of polls before we start discussing it. I want to point out that we will not have a conference next Thursday because it's the fellows in-service exam by ASN and ABIM next week, but we will have a special biopsy conference next Monday. That's 3 or 4 days from now. Monday at 6 p.m. We'll send a separate email for that, but we hope you can join us. We're doing this in conjunction with NANI, which is Nephrology Associates of Northern Illinois, a very large private practice group that is part of their educational conference. So we're going to do it next Monday night at 6 p.m. We hope you can join us at that one as well. It's a really great case, I guarantee it. So with that, I'll hand it over to Kelly. Kelly, you going to read the protocol for us?
Yes, I am. Can you hear me? Are you able to hear me?
You got it.
Perfect. Okay. All right. So here we have a patient that's 70 years old. She's a female. She has a past medical history of diffuse systemic sclerosis, which has been complicated by interstitial lung disease, hypertension, aortic stenosis, status post TAVR 6 months ago, and heart failure. She presented with bilateral lower extremity swelling, as well as worsening renal function and proteinuria for 6 months. The patient specifically remembers her hypertension and swelling worsening after her TAVR procedure, which again was 6 months prior to her current presentation. At the time of her TAVR procedure, her creatinine was measured at 0.8 milligrams per deciliter. 2 months later, her creatinine had increased to 1.23 milligrams per deciliter, and 5 months later, her creatinine had increased to 1.63 milligrams per deciliter. Serial UA since her TAVR procedure have been showing increasing qualitative proteinuria and trace blood. Her first UPC was performed 4 months after symptom onset and was measured at 7.6 grams per gram. UPC one month later was 8 grams per gram, and this is when her creatinine was 1.63. Regarding her autoimmune history, her ILD diagnosis was made about 10 years ago. Her systemic sclerosis diagnosis was made about 10 years ago, and this was based on a positive ANA, which was 1 to 1280 in a speckled pattern, a positive SCL70 antibody greater than 8, telangiectasias, Raynaud's with ulceration, GERD, sclerodactyly, tightening of the face, and then she also had poikiloderma. And she's been managed on MMF 500 milligrams BID by rheumatology. Her past medical history includes diffuse systemic sclerosis, ILD, aortic stenosis, and HFpEF. Her surgical history includes a TAVR, which was mentioned above. In terms of her social history, she denied alcohol, drugs, and tobacco. She has no family history of kidney disease, autoimmune disease, or cancers. She had no allergies. Her medications included lisinopril hydrochlorothiazide, nifedipine, hydralazine, 50 milligrams BID, and this was started 2 months after her TAVR procedure due to uncontrolled blood pressure. Lasix 40 milligrams BID, pantoprazole daily, rosuvastatin daily, tramadol as needed, and Celcept 500 milligrams BID. Her physical exam was significant for high blood pressure of 170/50, heart rate was 74. The rest of her vitals were stable. She was 5'5". She weighed 66 kilograms. Her BMI was 24. She appeared comfortable. She was resting on room air. She had no periorbital edema. She had no increased work of breathing, no crackles. She had 1+ lower extremity edema. And then she had on her hands, which I think we have pictures later, but she had bilateral contractures of her PIP joints. And then she had multiple skin findings, including telangiectasias over her face and chest wall. And then she had findings of Raynaud's in bilateral hands. She had perioral skin tightening and sclerodactyly over her hands. Her labs included, oh, and then we have a picture of those findings. Her labs included a sodium of 138, potassium of 4.3, fluoride 110, bicarb 21, BUN 40, creatinine was 1.7, glucose was 100, total protein was 6.5, albumin was 2.8, adjusted calcium was 10, total bili was 0.5. Her liver enzymes were all within normal limits. Her total cholesterol was 150. Her CBC had a normal white count with a normal differential. Her hemoglobin was 9. Her MCV was 90. Her platelets were 200. She had negative hepatitis B and C panels. HIV was negative. Her anti-PLA2R was negative. She had a positive ANA of 1 to 1280, normal complement levels. Her P-ANCA was greater than, her P-ANCA was greater than 1 to 640. Her MPO antibody was 3.6, which is elevated based on our lab assay. Her C-ANCA was less than 1 to 20. Her PR3 antibody was also elevated at 7.4. Her anti-GBM antibody was negative. Her SPEP and UPEP were unremarkable. They didn't detect any monoclonal protein. Her UA showed a specific gravity of 1.012, pH of 6, 3+ protein, trace glucose, trace blood, 3 to 5 RBCs, 4 WBCs. It showed a UAC of 4 grams per gram and a UPC of 6 grams per gram. All we had for imaging prior to the biopsy was a CT abdomen pelvis, which showed symmetric and normal sized kidneys. They did have a lobular bilateral renal cortices with some cortical thinning, but there was no hydronephrosis noted. And then we got a renal biopsy.
Great. Any questions for Dr. Whittier or Dr. Schlotman?
Do we know if there has been any changes in her blood pressure from prior to her valve surgery and then after?
Yeah, it's actually been a lot higher, and they've been titrating up medications. They increased her nifedipine, they increased her, they started hydralazine. Her blood pressure and then swelling kind of set in there too.
I know it's no eosinophilia.
Sorry, Raj, you were going in and out there. What'd you say again?
No eosinophilia.
Correct, no eosinophilia.
And along those lines, Bill, any changes in her vision or livedo reticularis type lesions?
No, no other skin findings than the significant chronic ones that we kind of saw in the picture there, and no vision changes. That I have to admit that I didn't look at her eye grounds.
This is Mario Rubin, not Dr. Classic.
Okay.
Bill, a couple other questions in the chat. Any antihistone bodies that were checked? Antihistone bodies?
They weren't checked.
Oh, okay.
They were checked when she was diagnosed, like way back when she was diagnosed with systemic sclerosis, and it was negative at that point in time.
Bill, my question was the timing of the hydralazine and associated with everything else.
Yeah, she started at 4 months, or she started 2 months after her TAVR, which was 4 months before she saw us.
Okay. All right. Well, we're going to start with a couple polls here, and then I'll have some discussing of the case here. So poll number 1, the biopsy will be done on a Friday of a holiday weekend, and the results won't be available until Tuesday morning. Do you pulse this patient with salumedrol awaiting results? Yes or no?
Wait, at least a little longer. Some good 70% of the people voting have already put in their votes. All right. We'll end it there. You should be
So
able to
interesting,
see-
we have about 50% yes and no, and that'll be, I think, one of the discussion points as we go through the case. And once we know what's going on, it might be something very smart. It might be something not very smart. And the second poll is, what do you think the biopsy will show? Do you think it'll show pauci immune GN, the ANCA-positive vasculitis? Do you think it says AA amyloid? Do you think this will be atheroembolic disease? Do you think this will be ATN with segmental scars? Or do you think a scleroderma renal disease? Scleroderma-related renal disease. Which do you think is going to be? Interesting.
Give it a few more seconds. Almost 75% of participants have already put in their vote. Last
Yeah,
few
it's a fun breakdown here. I'm a little surprised.
Yeah, there we go. We'll end it right. Oh, more. All right, we'll end it right there.
So we've got the winner is 50% say ANCA vasculitis. We've got a few amyloids, a few atheroembolic diseases, and a few more scleroderma renal diseases. So I'm glad we asked that because it kind of sets up the discussion a bit, which I want to hand over to Dr. Gashti. Casey, can you walk us through your thoughts on this case?
Casey, before you start, I just wanted to say that the biopsy question there and the empiric steroids was a very real question. We discussed it on rounds. It wasn't really a Friday, but there was a certain time we weren't going to get the biopsy back. And we really talked it over with my fellows and just tried to figure out whether we were going to do empiric steroids or not, knowing how important it is to give emergent steroid therapy if you think it's an ANCA vasculitis, and yet how hard it could be by precipitating a scleroderma renal crisis, as steroids are known to do that. And so this was a real dilemma in a real-time situation.
So first, I think, just going through the two poll questions, I feel like just reading the protocol that this woman started having worsening hypertension, worsening swelling, and elevation in serum creatinine right after her valve surgery. And it seemed, if I'm reading it correctly, even before hydralazine was started. So even if there is an effect of hydralazine or ANCA-associated vasculitis, which is drug-induced, which kind of we'll get into, my sense is that her changes in her renal function was actually occurring prior to that, which then knocks down, for me, the idea of vasculitis or drug-induced vasculitis a little lower because of just the timeline of how things happen. Having said that, we all kind of know that hydralazine is on the very top of the list of drugs that could cause vasculitis, and she has multiple autoantibodies that are positive, which also goes along with drug-induced vasculitis. Her titers are not as high as I usually expect to see with drug-induced. They're relatively they're high, but they're not 10 times higher than a regular ANCA-associated vasculitis. So that's on the differential. So definitely 50% of people thought it was some vasculitis. But she does have an underlying systemic sclerosis, and if her blood pressure was better because she had cardiac disease and she had aortic valve disease, and after the valve surgery her blood pressure went up, it's plausible to think that the hemodynamic effects of post-op period has set off some kind of a vasculopathy related to her systemic sclerosis, and in that case we would see more of a kind of a TMA endothelial injury type of picture on the biopsy. The other choices were ATN. I feel like that's, this is 6 months ongoing. Her blood pressure is not low, it's high. I don't really kind of like that idea because there's proteinuria has gone up. So I think ATN is probably on the very bottom of my list. AA amyloidosis, again, she has proteinuria, but it looks like it's kind of been there, and it's really the blood pressure to me that stands out after surgery that went up, and then all the changes happened. So I don't really like the AA amyloidosis here. So I'm really between whether she has some kind of a effect from her systemic sclerosis that could cause her AKI and increasing proteinuria. And I know that TMA usually is more of a change in GFR and not so much proteinuria. But if she's had this for many years and she was just hiding her creatinine because she did have some CKD from some chronic changes in her kidneys, this could just exacerbate it as her hypertension got worse. So I would not give her steroids because that's probably going to make her blood pressure control even worse. And I felt like that her creatinine rise is more of a subacute as opposed to an acute. So I don't see a sort of an RPGN. There are not that many RBCs. The creatinine is 1.2 to 1.6 over many months. So, 3-4 days to me is probably safe not to give her Solumedrol. I would definitely stop the hydralazine at least, but not give her steroids. And off the list, I think I'm going to go with systemic sclerosis related change. ANCA is interesting. I don't know if she had an ANCA prior to her recent presentation, if her ANCA has always been positive. If that's the case, there is a subset of patients with systemic sclerosis who have a positive ANCA. It's like, I think less than 10%, but they do have a worse prognosis. They do tend to have more lung disease. So I think her ILD ties into her positive ANCA if it's related to her systemic sclerosis and has nothing to do with the hydralazine. But as long as hydralazine is on board, I think everybody's going to focus on that. So I'm going to go with systemic sclerosis first, ANCA-associated vasculitis second.
Yeah, it's really hard in this day and age to ignore hydralazine. We're seeing more and more cases of it. And like you pointed out, you often have multiple serologic markers. And here we've got both, not just a PHC ANCA, but PR3 and MPO antibodies. But I think it's a good point that the titers aren't high, and oftentimes with drug-induced vasculitis, it tends to be very high levels. So I don't know, what trumps what, but you put your nickel down. So Dick, Dr. Glassick, what do you think's going on?
Well, I'd have to agree with Casey on this one because worsening hypertension is not generally a prominent physical finding in vasculitis. These patients do not tend to develop a marked increase in blood pressure, and with the background of scleroderma, I would certainly consider that the surgery triggered an episode of scleroderma renal crisis. The problem is nephrotic syndrome is unusual in scleroderma renal crisis. I'm not saying that it doesn't occur, but it certainly is not a prominent feature. I too would tend to disregard the serology here, largely because it may be hydralazine induced, but it doesn't necessarily indicate that there's an underlying vasculitis. She clearly has nephrotic syndrome. What also impresses me is that she was on MMF prior to all this happening. And if we believe MMF is therapeutic in vasculitis, why did she develop it while on MMF? So all the things taken into consideration, I would favor Casey's diagnosis of scleroderma vascular disease.
Yeah, those are all good points. I want to put Mario, Dr. Rubin, a little bit on the spot here. I had a long discussion today with Dr. Whittier about scleroderma renal crisis. Is it a single event or is it a spectrum? In other words, both Dr. Gashty and Dr. Glassick think it's a scleroderma-related renal disease. If you notice, I didn't put renal crisis in the as one of the choices, kind of leaving it open with this in mind. Mario, do you think it's an all or nothing, or do you think it's kind of a spectrum?
I think it's a kind of a spectrum. But again, I mean, I'm more impressed by the patient saying everything began when I underwent the transaortic valve replacement. And there is this entity called atherosclerotic renal disease, which again, you and I were, I guess, thinking along those lines. You ask about eosinophilia, I ask about livello reticularis, and interestingly, I always tell I've never seen a case, but it's reported in the literature. The classic paper, and I just looked it up because I didn't remember, was from the VA hospital in Albany back in 1969. Those patients were nephrotic. So again, it could have led to microinfarcts. That may account for the hypertension, nephrotic range proteinuria, etc. That will be my 2 cents on this case.
Yeah, that's a really interesting point. I don't remember if it was in communities or Twitter, but this concept of atheroembolic disease came up recently, and I put out there that I have seen a few cases, but it's been 20 years, and so I put it out there. Does anybody see it anymore? And there were very few people that see it. So it became a kind of a popular or common, or at least not rare diagnosis 20 years ago, and something happened to it, and it wasn't, people see it, but pretty much everyone agreed they don't see it much anymore. And the question is that because of is it the technology of how they do cardiac cath different? They're not always going through the leg anymore. Idea being that going through the leg, it goes past the atherosclerotic aorta and knocks things off, or now they do a lot of them through the wrist, or they're in shorter. But I can't remember the last time that we saw one.
Yeah,
Whether you go through the leg or you go through the groin, you still have to get into the aortic arch, and that's the issue, right?
Well,
Right.
they're doing it through the wrist now, Steve.
But even if you go through the wrist, right, you still have to get into the aortic arch.
Oh yeah, you get the aortic arch, but you're not
Yeah,
getting
yeah.
exactly, but you're not going through the whole atherosclerotic aorta all the way up. But yeah, you're right.
They're using a basket now to trap the dislodged material, so that may account for the decrease in the episodes that we see.
I had no idea that was the case. And someone, better lipid management, of course, is a big part of it too. It was mentioned in the chat that, low C3 has been described, and I haven't seen that as much, but I've definitely seen eosinophilia. I think that was a huge clue to me back in the day. But
Actually, it's low C4, not low C3.
It's
But
just low C4?
I think so, for
Okay.
atheroembolic disease.
Yeah, I honestly don't remember. I just know it's in that vague hypocomplementemic renal list that's thrown around a lot. Steve Corbett, before we spin the wheel, what does this patient have?
Well, if Dick agrees with Casey, far be it from me to go off the path here. I think Casey did a nice job. I was just trying to think as well, why would the patient be this nephrotic? And, I don't know if this is related to the scleroderma and hypertension, or whether there's some membranous lesion that's lurking as well. I don't know. I agree with all that's been said. I too was perplexed by all this autoimmune stuff, which probably could all be attributed to the hydralazine. It doesn't necessarily mean that she has vasculitis, but I wouldn't be surprised if she had mesangial deposits, which you wouldn't expect necessarily with scleroderma. So,
Mesangial deposits from
immunofluorescence from the hydralazine. You can have mesangial lupus, if you will. I mean, her ANA is elevated. I don't know if that's because
you expect 6 grams of proteinuria with mesangial.
No, that's what I'm saying. No, I don't. And that's why I say there could be a membranous lesion, or she may have, for whatever reason, secondary FSGS, or even, foot process effacement for whatever reason. Yeah, I mean, I agree. I can't scleroderma unless it's, uncontrolled hypertension, I believe, can occasionally give you nephrotic range proteinuria. But there's so many potential possibilities here that I look forward to seeing the biopsy just like everybody else does.
Yeah, I want to get back to one thing Mario said, because I do remember those. I don't remember if it was the first paper, but I do remember, I think it was a New England Journal of Medicine paper. Maybe that's the one you're referring to, where these patients with atheroembolic disease some of them did have very significant proteinuria. And again, I don't know if that's a hyperfiltration injury or what, but
those were, we wrote our series up years ago, Kashi and Howard. I forget how many patients we had. And the whole issue of acute atheroembolic disease was where you saw the eosinophilia. You saw the staggering kind of, stair-step like progression of the acute renal failure. It wasn't like contrast where it goes right up and comes down, because that was always the dilemma, right? Was it the contrast from the cath, or was it atheroembolic disease? So the eosinophilia, was one, which you saw more with the acute atheroembolic disease, the stair-step kind of staggering course of renal insufficiency. you know, did they have amaurosis fugax, which is the other thing? And as Mario alluded to, the whole issue of libido reticularis. But yes, I can't remember if it's New England Journal, but there are these patients that have these more indolent chronic atherosclerotic diseases, which may actually, I think, develop ultimately over time focal sclerosis. And they don't get eosinophilia. I think I think I know what you're talking about, Roger. And I think it was New England Journal, but it isn't always just this acute, you know, kind of sudden onset like we see post-cath. It can occur way down the line.
So Steve, before I spin the wheel, what's the path going to show?
Yeah, I already balked on it once.
Yeah, but you know, you'll get away with that.
I think we're going to see evidence of thrombotic microangiopathy from scleroderma. I mean, you probably see onion skinning from like a scleroderma crisis. I personally think you'll see immune deposits in the mesangium. And, you know, I don't think we're going to see vasculitis, which is a big, you know, one of the big issues here from hydralazine for the reasons that have been, I mean, you can get a positive PR3 or MPO, but does that necessarily mean she has active lesions in the kidney? I don't think we're going to see it. And I agree with the whole point about these titers, as we've learned, you know, in the past, aren't that high. Doesn't still mean it couldn't be associated with hydralazine. And I think scleroderma findings, mesangial deposits, and I must take a stab in membranous.
Great. So let's spin the wheel. I'm going to put it up. Saba, Dr. Munir, our first-year fellow, is going to read the biopsy.
All right, Saba, give me a quick second here. You should now be able to unmute yourself.
Okay, can you hear me?
Yep.
Perfectly.
And then I'm going to give you control.
Can you hear me, Roger?
Yes, David.
Okay.
Let's see here. All right, go ahead and click on the screen.
David's getting ready to disagree with us, so you want to make sure he's on mic.
Remember, there's a little lag, Saba, so you can advance the slides at the bottom. Yep, go for it.
Sounds like very few people would have given IV solumedrol then empirically, but we had it was 50-50. So that's interesting. As far as the discussants, sounds like most likely the differential was scleroderma.
Well, I think it's as you said, Bill. I mean, if scleroderma is high in your differential, that can potentially exacerbate. You could tell us more about that later, but I think that was really why I wanted to throw that question in there. I'm sorry, Saba.
It's okay. Should I start?
Yep.
So first slide is going to be trichrome stain. So there's two cores that I see here. Looking for the blue material for fibrosis, or sorry, scarring, and there's maybe like 15-20% here. This core I don't see as much, but there is some scarring here. That's what I have.
The top core is mostly cortex. You could see, you know, glomeruli throughout, and over near the top. Yeah, you can even make out a couple sclerotic lobes there. And then there's some fibrosis just to the right of your arrow. And then the bottom one is mostly medulla, actually. But yeah, overall, it was kind of mild fibrosis, about 30%.
Okay. All right, so here we have our H&E stain looking at a glomerulus. Just kind of looking at it overall, it looks like maybe it might be a little bit collapsed on the outside. I do see that the mesangium, there's like mesangial expansion kind of throughout here.
Yeah.
And maybe there's some areas of hypercellularity as well, kind of like here.
Yeah, the capillary loops look open, so I wouldn't have used the word collapsed. It's kind of dislodged from the core. But just where the arrow is, look at that capillary wall. Yeah, right there.
It's really thick.
Yeah, really thick. There's even some nuclei in the periphery there. corresponding to like mesangial, interpositioning and remodeling. And then if you go immediately to the left of that, there's another thickened capillary wall as well. Yeah, right there. Yeah.
Well, they really do look thick.
Yeah, kind of all
Exactly.
throughout.
It wasn't really a thick loops wasn't really one of our parts. Interesting.
Well, I
of
mean,
our
David's already,
discussion.
he's already describing the whole issue with the nuclei interposing there. I guess the question is, does this have a lobular appearance to it as well?
And remember, there's other, I mean, thick could be, it was, membranous was on Steve's differential that he mentioned. And I think, if we think about interposition and thickened loops with that MPGN pattern, chronic vascular disease, if the immunofluorescence is negative, is a classic cause of that.
Yeah, right. TMA, right. Exactly.
Yep.
Good point. Excellent.
I guess lobular was the word that I was thinking of earlier, but okay. So this is a PAS stain and it looks fairly prominent throughout this glomerulus. Again, I see a little bit of this mesangial expansion. And then the tubules look okay. I mean, I guess there's some loss of brush border here.
Yeah, like in the tubule below that one. Yeah, there you see some sloughing of the epithelium into the lumen. So yeah, a little bit of ATN. But overall, yeah, this glomerulus doesn't look quite as bad as the previous one. There was a little bit of variability between them, so I have photographed a few of them that we'll see.
Okay. So again, another PAS stain. The capillary walls here are pretty thickened as well, especially up around this area.
Yeah, so looking at that area as a whole, from 10 o'clock to 1 o'clock, yeah, that whole segment. See, most of the loops are open. Yeah, from 10 o'clock to 1 o'clock, up where you were. There's an early segmental scar there, up to where you were.
Okay.
Up there, yeah, that area is segmentally scarred. Just to the right of that, there's a right there. That's a podocyte with protein droplets. That pink blobs right there.
Yes.
Yeah.
Okay.
So that area is kind of collapsed and segmentally scarred. So this glomerulus has a segmental scar, early one.
Okay. And is this scarring kind of here as well?
No, I mean, what do you recognize what that vessel is right there?
No,
You're right at the hilum. So
Right.
yeah. Now, we're going to see this glomerulus on the H&E on the next one. And actually, I think that light pink material that you pointed out are old thrombi.
Okay.
Because on the next stain, we'll see that it looks like they're intracapillary. Yeah.
Okay.
So this is the same glomerulus now on H&E, and you have that arterial coming in. Yeah, right there and over to the left of that and down to right there. Yeah, you can see the lumen's occluded by what I think, what I interpret to be an old thrombus. It's kind of lighter acidophilic than an acute thrombus, and there's no longer schistocytes and carectic debris. So I think this supports like a chronic, thrombotic microangiopathy.
Okay. Yeah.
David, why isn't that just a segmental scar?
Because I think it extends into the arterial coming into the glomerulus, outside of it.
Got it. Good answer.
Yeah, and then also I could kind of make out that there's a curvature where it looks like it's within a capillary as I trace it around. Yeah.
Okay.
And then also when I look at it on the trichrome and other stains, it was more conclusive that this is an old thrombus.
David, on the prior slide, so I just went back on the top left at, I guess, right there, is that arterial, sorry, artery? It's pretty,
Yeah, it looks like an old artery with,
Mhm.
Severe sclerosis and some onion skinning.
yeah.
It's interesting that the glomeruli are not really retracted away from Bowman space that we often see when they're severely ischemic.
Yeah.
Sorry, go ahead, Saba.
Okay. Again, here I see a decent amount.
Oh, yeah, so this is, we just described this glomerulus. We could go on to the.
Okay, next one.
To the next slide, yeah.
Okay, so this is our Jones stain. I'm looking for any breaks in the capillary walls, any spikes or holes. And I don't think these are holes, are they, around here?
Yeah, that's in the mesangial area. But I do see, if you go right in the middle of the glomerulus, yeah, and up to the left just a little bit. Keep going up. Yeah, that capillary wall and to the right of it. What do you think about that one? Yeah, that one there. Kind of circle that one around, go up. Yeah. What do you think about that one?
It looks thickened. Is this like the double
That's right.
contour
Yeah.
wall?
And if you go straight up and to the right, like Casey said, around just a little to go straight up. Now go to the left.
Oh,
Keep going. Keep going. That glom there, see the nuclei there? Now straight up from there,
my God. Okay.
right
You're
there.
getting warm. You're getting warmer.
There you go. I mean, Casey
You're
pointed
getting
out.
colder.
Look at those nuclei now. They'll talk about mesangial interposition. I think
Yeah.
that's a pretty good example.
Yeah, that one right there, exactly.
Yep.
Yeah.
Remember, even though Dr. Glassick had to leave early, that MPGN pattern is a pattern of injury with multiple pathophysiologies. But it is interesting because as Bill pointed out, that's a lesion that can be seen and associated with microthrombopathy or severe vascular disease. So it doesn't have to mean we'll get a better idea when we see the immunofluorescence what it means.
And the EMs with ischemia, you get the endothelium gets lifted off the basement membrane as well. Did I call this one or not? What's that lesion?
I don't know. I think it took me 3 times for you to say it, but I think you may have.
So this is pretty prominent onion skinning here. So consistent with the scleroderma that we were talking about earlier.
Yeah.
David, how?
Go ahead.
David, how specific would you say the onion? I mean, we use it classically for scleroderma, but how specific is it for scleroderma versus just really bad hypertensive damage? Is there any specificity, or is it just part of sorry?
No, it's specific for thrombotic microangiopathy. It's rather related to TTP, scleroderma, or whatever the cause.
What about eclampsia? I thought even in eclampsia you
Yeah. Among other causes. My list wasn't
so-called malignant.
But eclampsia is a TMA and malignant hypertension is a TMA. I mean, it's an interesting question that I thought of it more as a pressure thing, and David's saying it's more of a thrombus thing. It may be a combination of both, but I'm glad I asked because I kind of think of it more as a pressure thing.
No, I mean, through the years, I remember actually Bill showing, at our old biopsy conferences, there was young African-American males who had hypertensive crisis, 220 systolic pressure, and they would have, onion skinning in their biopsies.
Yeah, but that's also TMA is associated with that kind of blood pressure. So it's hard to, they kind of go hand in hand.
No, that's why I'm saying you can see this in TMA of multiple causes.
Okay.
Not just scleroderma.
Yeah.
Okay. Another, I think, is this also PAS stain?
Yeah.
Kind of, again, we're seeing this vascular sclerosis here, think these are
Yeah,
all-
so those two arterioles to the right aren't too bad, maybe a little narrowing, but that one right in the center, to the left a little bit,
Oh,
that one, yeah. Yeah, see that we have that waxy, shiny material, we call that hyalinosis. Hyaline means glassy or waxy. So, you know, you have severe arterial or hyalinosis with just a pinpoint lumen left.
Mhm. Yeah, it's pretty significant. So immunofluorescence is negative.
Yeah, there was no membranous or any immune complex disease.
Okay, so
You know,
this
if you remember, and Bill loves this, it's his favorite figure ever, is the MPGN figure from New England Journal of Medicine, 10 or so years ago. But it's all, if we're going to look at this as an MPGN differential, which is just many ways to approach this case, but you go down the MPGN, it's really based on immunoglobulins. So when you end up with nothing, it's not monoclonal, it's not immunocomplex, it's not C3, you kind of end up with, I don't know, is there anything besides TMA, Bill, that gives you that MPGN picture with a negative IF?
No, I mean, it's all chronic vascular disease. You could see it in sickle cell disease, for example. So that's not really a TMA as much as it's chronic sickling, but chronic ischemia, I think, is the point.
Okay, Sub, I'm sorry.
It's okay. So this is our EM slide. Just looking at the basement membrane. It's kind of hard on here to tell if it's thickened or not, maybe like right around here. I do see podocytes throughout. There's maybe like a little bit of effacement in some of the areas. And then
Yeah, overall it was kind of partial, about 50%, like we see here in the picture.
yeah, and then within the basement membrane itself, I don't see any deposits. And then I don't think these are deposits.
Yeah, those are organelles. Actually, the endothelium, you know, in these lumens is swollen. You know, we don't see a good lumen, and that's like a cross section through the endothelial cell.
Yeah, so I don't see any obvious deposits here.
Yeah.
David, would you say, you want to go back to the previous slide?
Sure.
Thank you. Would you say that the GDM is wrinkle consisting with glomerular ischemia?
Oh yeah, good observation, Mario. Yes, there was wrinkling there. Yeah, thanks for pointing that out.
No, thank you.
Yeah. Now here's Saba. Look at that capillary in like the bottom half of the picture in the center. What do you think about that one?
One.
Yeah, that one there. Yeah.
So again, I don't really see anything within the basement membrane itself, but are
Yeah.
these
So put the arrow right in the lumen.
here?
That's the mesangial area. That the lumen is the clear area. That you're in.
Oh, sorry,
You're in-
right.
That's urinary space. Capillary lumen is in the middle, right? Yeah.
Okay.
Down a little bit. Well, anyways, I wanted you to trace around the capillary wall. If you go down to like 6 o'clock,
Okay.
all the way through 3 o'clock, you see that's all thick in there. Yeah, that corresponds to our double contour on the Jones stain. That's what we call mesangial interpositioning. There's mesangial processes creeping out. And there's the endothelium, you're on the podocyte there, but on the inside is where the new endothelium is. So it's a markedly thickened wall.
Okay.
Yeah, now you're in the lumen.
Okay, good.
Yeah, so just to the right of that is the endothelium. Yeah, so you can see how massively thickened that wall is. That was corresponding, yeah, to the double contours that we were seeing on the silver stain. And then the one up to the top left, you don't see as prominent mesangial interpositioning. So it was kind of, involving some capillary loops and not others.
What about the foot processes?
They're from what I can tell, they look effaced.
Yeah,
on
I mean,
this.
I agree. I don't know if David's going to give us a higher power, but they look pretty wide. There's like widespread effacement for whatever.
Yeah. In this picture, like I said, overall, it was about partial 50% of the biopsy. And then
Let's move-
also right around in the middle, that there are some little mesangial, like Dr. Corbett said, there are some little mesangial deposits there. Yeah, right there and to the right a little bit.
Right here.
Yeah, and up and to the left a little bit. Yeah, right there. Yeah, some little mesangial deposits.
Okay.
Well, excellent. We're pretty much all in agreement then on the biopsy and the histology. Nice read, Saba. This is a chronic TMA is some complex histopathology. So good description.
Super, nice read, Saba, and nice pictures. I'm going to move things along here, but very quickly, Casey, how would you treat this patient based on what you saw? Would you immunosuppress, change anything? Change blood pressure management?
It seemed like before surgery, when the blood pressure was fine, the MMF covered the systemic sclerosis without any renal issues. So I think it's the really added hypertension that's the added pathophysiology here. So I'll focus on blood pressure control. And I wonder if, since this is an endothelial damage issue, if the the double endothelin inhibitors, the aprocitentan or something, the precision trial, if that kind of stuff will help.
Yeah, that's a really good point, and I think patient is on lisinopril. Okay, so you just want to continue what you're doing and think about adding a little more blood pressure control.
Yeah,
Bill.
And no hydrolysis.
Bill, I'm going to hand it over to you because I think I don't want to run out of time here. Take your time though.
Sure. Yeah, we first of all, we did not pulse her with IV solumedrol. She was actually transferred in from a nephrologist who, was convinced it was ankylosing and we needed to get in for an RPG treatment right away. And we thought, well, let's just wait and see the biopsy results first, because I was a little bit worried with the sclerosis, with her scleroderma. So we didn't do that. And I think we were fortunate, it could have been ankylosing that was on the biopsy too. It was clearly in the differential, and then I would have been behind the 8 ball on my treatment. So yeah, we really wanted to focus in on better blood pressure control, which was difficult because she's on a lot of medicines already. And she has such tight arterioles already. We drop her pressure a little bit and her creatinine could go up to 1.7 again. After the biopsy, her creatinine came down to about 1.1 again. So there was a little bit of and as I've been treating her blood pressure to get it under control a little bit, it's already back up to 1.5 again or 1.6. And so I think we're just going to have to accept a little bit of azotemia for the sake of good blood pressure control. I think I can probably take this.
Yep, you're controlling the screen.
Oh, good. Thank you. There we go. So I thought one of the really interesting parts about this case was, scleroderma is interesting enough as it is, and so is ankylosing, but I really was searching the literature to find out how much crossover there is between the two. And what I found immediately was that there's a decent crossover, that quite a bit of patients with systemic sclerosis, which of course is what we call scleroderma when it's systemic, have ANCAs. And so the first things I found is that how many of these patients had ANCA-associated vasculitis who had scleroderma. And this paper looked at their systemic sclerosis database of over 3,000 cases, and they found only 7 of them out of the over 3,000 had actually ANCA necrotizing GN. They were all with the MPO positive, and they all had vasculitis, and that got varying treatments with various results. But that's not really what I wanted to find out. I wanted to find out how many patients with scleroderma have a positive ANCA that may not have any utility to the case at all, just like in our case. And so I found this paper, which was 185 patients who had systemic sclerosis, And they went back and looked through all of them that had to find how many of them had a positive ANCA. And they found that actually about 20% had a positive ANCA. And I think Casey mentioned this when he was talking about the differential, that it was a known situation where systemic sclerosis can have a positive ANCA. Now, our case had MPO and PR3 that were positive. And so in this population, they broke it down by those that had those different antibodies. And, you know, a lot of them were just the, here's the ones that had isolated PR3, isolated MPO. And then our case, we had a PR3 and an MPO. They only had one of those out of their 185. So that would kind of fit into what our case was. And again, who knows if these patients were on hydralazine, et cetera. In our case, we had stopped the hydralazine, and about 2 months later, we repeated the titers, and her PR3 and MPO were still positive 2 months after cessation of hydralazine. So I'm thinking that they were there all along. As Casey had even mentioned his differential, or sometime he said, how long, maybe their ANCA has been positive the whole time in this woman, and we didn't have that data, but it was obviously sensible to stop the hydralazine. So there is this intermixing of ANCA vasculitis in the setting of systemic sclerosis, which I really learned a lot about. When I think about systemic sclerosis, I think about sclerodermal renal crisis, and most of those are in the hypertensive patients. There is, interestingly, a normotensive sclerodermal renal crisis, maybe a little bit more chronic, but it's really hard to distinguish between the two. And I hope that our case today highlighted that. It was a really difficult decision, so much so we weren't sure if we should even empirically treat with IV sodium medrol. But here's kind of the differential of renal associated disorders, focusing in again on our case that had ANCA. So it's kind of difficult to differentiate sclerodermal renal crisis from ANCA associated vasculitis. And this paper really went through that and talked about how you can kind of try to figure it out clinically before you get to the biopsy. And Dr. Glassick had mentioned, I think he's off the call now, but Dr. Glassick had mentioned that it's very rare in ANCA-associated vasculitis to have significant hypertension. And he of course, is right. We see that often more with sclerodermal renal crisis, and it's more mild in ANCA-associated vasculitis. So that might have been a clue, not to empirically treat before the biopsy. The ANCA vasculitis, though, occurs years after scleroderma onset, and usually this is within 4 years of onset. But our patient didn't necessarily really have a sclerodermal renal crisis. What I think that she had was the same thing that was going on in her fingers and her face was going on in her kidney. It was sort of a chronic remodeling of the vasculature leading to ischemia, leading to this MPGN pattern. You don't get that MPGN lobular pattern overnight. You get that with chronic ischemia over years. And so I think that hers was really sort of just long-term scleroderma, not necessarily a crisis. And then since we had mentioned the normotensive scleroderma renal crisis, I just did want to put this up. And then obviously most of them are hypertensive, but it can exist in normotension. And it's pretty hard to treat because the ACE inhibitors just don't seem to be as effective as they are, and with such excellent response with ACE inhibitors to treatment of scleroderma renal crisis.
It's a really interesting point, though, because if there's such thing as normotensive scleroderma renal crisis, even though it's rare, you really have to, it questions the pathophysiology a little bit of what's going on. What is the chicken or the egg? You know, it's hard to believe if you have that much arteriolar disease that you wouldn't have hypertension. But maybe it's the arteriolar disease that's really the problem, and the hypertension is what, really brings on the acute problem. But
and the other dilemma that you were mentioning earlier with David is it a thrombus that's doing a lot of it, or is it chronic ischemia leading to remodeling and onion skinning? And it's really hard to sort out because there's not always thrombi, but there's, I think that's a really impossible question to answer. And this is tough too. To me, she was a sort of, I wouldn't call it normotensive because she had hypertension, but she was sort of this chronic, ischemia, not huge spikes of hypertension leading to crisis over time. And besides, she'd been on an ACE inhibitor the whole time anyway, and they had been aggressively treating her hypertension. Again, everything seemed to go haywire after her TAVR, again, like Casey had mentioned. So interestingly, I was thinking, okay, well, let's say she's got an ANCA vasculitis and she's got systemic sclerosis. Is Rituxan good for both? We often will, me, Rituxabil, why not find a new disease that I could use Rituxan for? And actually in this meta-analysis, Rituxan was quite good for skin disease and also the interstitial lung disease. They didn't compare it to MMF, but it's interesting to know that that Rituxan can be used for systemic sclerosis independent of the renal disease if it were ANCA-vasculitis. Now, I reached out to the rheumatologist to see if they thought Rituxan would be a better alternative than Cellcept, but they thought that her interstitial lung disease and her skin disease had been pretty stable over the last 2 years on MMF. And so they weren't that excited about changing her treatment. And I can understand that too. And then lastly, I think it was kind of mentioned here about the corticosteroids and the risk of scleroderma renal crisis. I don't really like the idea of the mechanism here, because I think about scleroderma renal crisis being a renin-mediated hypertension, so much so that obviously we need ACE inhibitors to block that. If anything, I think about diuretics as exacerbating scleroderma renal crisis because it will exacerbate renin use, and we may see that after someone gets put on a diuretic, that their renin goes up very high and could precipitate crisis. But there is an association in the literature, and this was a positive article, it was a positive meta-analysis looking at the association of scleroderma renal crisis precipitated by steroids, and there does seem to be an association there. So whether it theoretically makes sense or not, there's enough in association that we probably would want to avoid them if possible. And so that also begs the question, if you have somebody with a vasculitis, should you be giving them steroids along with the Rituxan? It's somebody that if that happened, I would certainly be weaning steroids as fast as possible, or maybe even going to something like Avacopan that would be a lot more steroid sparing along with the rituximab. So that's all I have, but I just thought it was very interesting. I love the idea of, the endothelin antagonist. And so thanks for bringing that up. I'm gonna see if we can, that might actually help her too. So I like that idea, and I'll see if I can get her on that.
Bill, she had telangiectasias and things. I mean, was there any thought that this was Crest syndrome?
Yeah, I mean, I think a lot of it's overlap.
And because she has lung disease, and lung disease is more common, I believe, in Crest syndrome.
Right, and she has the interstitial lung disease, the telangiectasias. I'm not sure anybody called it that, but to me, it's the same. It's a spectrum of all the.
There's no difference in how you handle a kidney or the risk of crisis, or.
No, not that I know of.
Plus her SCL70 was elevated. I don't know what the anticentromere was, but doesn't that go along with it as well?
That's right.
Go along with what?
Crest.
I don't know, Steve. That's a good question.
I thought her SCL70 I thought was pretty high.
I thought SCL70 was just a scleroderma thing, but it might be more of a Crest thing. I really
well,
don't
that
know.
or I mean, I know the anticentromere I think goes along with Crest too, and I didn't see that one down there, but
yeah, that's the one I remember. Good, yeah. Well, I'm going to wrap this up. Anybody have any more comments? I think we're left with a patient who has, as Dr. Glassick kind of alluded to, some positive serologies, probably from hydralazine, but not pathophysiologic in the relationship to the renal disease, and a picture, of chronic scleroderma and all the vascular changes that are associated with it, including TMA and chronic TMA and double contours, ischemic glomeruli. A little odd that there's this degree of proteinuria. Maybe that was some segmental scars. Dr. Suki was just asking that. Maybe there's some segmental scars. And, when I looked at the EMs, I saw a fair amount of foot process. There were two of them. One of them looked pretty well effaced. The other one was maybe, I don't know, 70%. I think David read it lower, but I was fairly impressed by the foot process effacement. Dr. Corbett is shaking his head, which always makes me happy.
Two things, if I could just add before we wrap it up. I think hydralazine was a bit more of a red herring here, Roger, because you never know, but after we stopped the hydralazine 2 months later, her PR3 and MPO were still positive. And
what about the ANA? Was it positive still too?
We didn't repeat that, but I will.
I'm just curious because that was, we always talked about drug-induced being more single-stranded as opposed to double-stranded. And I think the antihistone was an interesting question because that usually goes along with, lupus. But yeah, I was curious. So it probably was, it probably wasn't associated, might have just been related to her underlying autoimmune disease in general, you think?
Well, that's
as Casey had alluded to, actually, I think.
That's why I showed that one slide, which is the percentage of positive ANCAs in the setting of systemic sclerosis is 20%. When there's no actual vasculitis clinically present. And so I think it's much more than association with scleroderma as opposed to hydralazine.
I think,
Obviously, we're not going to be hitting her. We're stopping her hydralazine.
but I think
Casey
you know,
made that point when he brought
Yep.
it up, and I
Yep.
didn't know that. I certainly didn't know it was that high. So
I think the interesting thing here is the biopsy was very helpful at the end. I mean, there were so many things going on that the biopsy, was, I think, a critical piece of information, really, because there, as you alluded, some people might have pulsed her. I mean, there are all kinds of potential issues here, and the biopsy really kind of brought it back home as to what was really going on to help you direct your therapy.
yeah, you're absolutely right, Stephen. You think, there's kind of more of a movement of using serologies to guide therapy without a biopsy. And you could say this is hydralazine and this patient has vasculitis, and we'll pulse and we'll give rituximab. And, that's not the case here. So
Well,
it really
especially
was.
with, if you have one serologic marker, that's fine. But when you got 5 things going on at once, I don't know how you can sift through all of that.
Yeah, absolutely.
My recollection is that the ANA, a speckle pattern, can be positive in scleroderma.
Yeah,
Sure, I don't doubt that at all.
Yes.
yeah, that's probably part of that, Mario. You're right.
Yeah, and when you saw a speckle, that's when you do an anti-centromeric to rule it out, in addition to the clinical history.
I mean, she seemed like an overlap syndrome to some degree. I mean, she had all these things going on.
And I think that, as Dr. Suki was asking, I think her nephrotic range proteinuria was really just that. She didn't really have nephrotic syndrome. She didn't have edema, significantly low albumin. Her cholesterol was normal. And I think that goes along with secondary sclerosis, global sclerosis in the setting of hypertension. Hypertension, of course, doesn't cause primary that much proteinuria, but when there's that much global sclerosis and focal sclerosis, and certainly when the MPGN pattern is there, you can imagine when there's that high of an intraglomerular pressure from systemic hypertension, that it might push out a lot more proteinuria. So I wasn't really surprised once I saw her biopsy by the degree of proteinuria that we had.
By the way, I want to clarify something. Both C3 and C4 are low in atherembolic renal disease. I put the key paper in the chat by Fernando Cosillo when he was at Ohio State.
But nobody's really understood what activates complement in that setting. I remember reading about this. I don't know that there may be in that paper, but I don't know that there's ever been a good explanation as to why that happens.
I thought it was an in vivo. I don't understand.
I mean, for that matter, why do you see eosinophilia and super high sed rates? Something's very inflammatory going on. But yeah, and one thing I noticed about that paper, the C3 and C4s were low, but they weren't 30 and 2. They were mild hypocomplementemia. But
right. Yeah.
regardless, I'm going to wrap this up. I want to thank everybody.